Hello, everyone. Good evening, and welcome to the first episode of the season two of My Most Memorable Case. My Most Memorable Case is a conversation type of a podcast series brought to you by Metro in association with Sun Pharmaceuticals. Without further ado, I'd like to invite Dr. Om Lakhani sir, who's an endocrinologist in Ahmedabad, and a lot of us have followed him over the course of the first season, and we're very excited to uh, unpack what we have in the next season. So over to you, sir.
Yeah, thank you, Haley, and good evening, everyone, and welcome to season two. I can't believe that we have crossed season one. So welcome to season two of my most memorable case. And in season one, if you remember, we had taken some really interesting stories. I think there's some of them which are still kind of created, sort of a little bit of a dent in my mind. So if you're not watched season one, I would say there's some really fantastic real life clinical stories uh, told in a story from one of the best experts in the country, and I think you'll really enjoy that. But while you go home and watch season two later, season one later, we are at season two right now, and today we are going to do something very interesting. We are going to get a story with Dr. Rishi Sethi. I'll introduce you, Dr. Rishi. In fact, I'll ask Dr. Rishi to introduce himself in a minute. But just today's title, we are going to talk about what is known as lusus naturae, which is basically a term. Lusus is basically a term for cruel trick, right? And we're going to talk about some stories of arterial aberrations, which are basically cruel tricks of nature. And though other fields may not be that cognizant of these arterial aberrations, the cardiologists who keep seeing the blood vessels all the time, they are the ones who are going to face this day in and day out. So today, it's an absolute pleasure to have somebody who is really dynamic, who is really interesting, Dr. Rishi Shetty. And Dr. Rishi, you know, in season one, we started this little tradition where we are not going to formally introduce you, but we want to know your story, right? Your story of your life. So, of course, we'll know this your clinical story, your most memorable case, but we also want to know what brought you to cardiology, right? How your journey really started, and a little bit about yourself, right? So we want that in your own words. So welcome, sir, and a little bit about yourself and how you ended up becoming a cardiologist and where you are.
Hi, so good evening, Dr. Roman. Really a pleasure to be here and interacting with you. So I kind of call myself a Lucknow boy. I grew up in the city of Lucknow, and I kind of embody most of the things that people associate with Lucknow. So I'm in love with literature, culture, food, and of course medical profession on one side. But I feel that all of us in medical profession should not define ourselves only with we are endocrinologists or cardiologists or what is our post, but actually kind of that should be 50-60% of our persona. But as far as cardiology is concerned, I don't know. I never had any doubt in my mind ever since I stepped into MBBS, which was again by accident. I was never really a very good student in my class 10th or 12th. Uh, but I was always into extracurricular and debating and music and literature, but I didn't study. So, but anyhow, I got to KGMU with sheer luck, God's grace, destiny, whatever you may call it. But once I entered, I just somehow I never thought about it, but I always thought that cardiology is something. I never thought about anything else. And medicine, MBBS happened on the way, medicine happened on the way. Uh, MBBS again, I was hardly studying. I was all into extracurricular and friendships. And MD was a very intense phase, which I had to clear to get into DM cardiology. But it was very intense, very harsh. So MBBS and MD from King George's Medical University. Then I joined SGPGI for 1.5 years for training. Then I came back to KGMU to do my DM. Then completed my DM here, joined as a pool officer, then as a faculty. Then took some time off sabbatical, went to do a fellowship in National University Hospital in Singapore.
Right.
And so between 2009 and 2011, that period. And since then, I'm in I'm the same alma mater, same parent institution. So I'm stuck to the city of Lucknow. I'm stuck and married to KGMU.
Right.
I have a wife who's also a senior academician, a doctor, and a radiation oncologist,
Right.
and I have two lovely daughters. So that's who I am.
Great. Fantastic story, sir. And I think, I would say, if you didn't tell me that you are from Lucknow, I know that you're from Lucknow, right? And you are, like you very rightly said, I think you spent most of your life there. You are the true kind of, embodiment of the city. I think, the everything about you, the posture, the way you speak, the way you, and one more thing, which, makes you a true Lucknow person is your book, right? So I think,
Oh,
I mean, you probably don't, you can't call yourself from Lucknow unless you write a book, right? Isn't that? So that's your passport to being in the city, right? So tell us a little bit about your book, sir. This is this age. I looked it up. Very interesting. I mean, the entire premise also sounds very interesting. A little bit about your book and how you got about reading and sort of writing a book. Uh, you know,
so I would not say I'm a very extensive literature buff. I
right.
did used to appreciate literature when I was in school,
Mhm.
but I would be having almost all the classics and all the book in my library and my bookshelf, but I've hardly read a few of them. So my daughters asked, "What are these books doing in your bookshelf when you have not read them?" So I said, "So are the number of wines in my cellar, but I've not drunk all of those wines." So it's
Right.
always nice to have a collection that you see. But
Yes.
there are a couple of books that did influence me when I was in school, and it was a diverse plethora. I don't say I've read extensively in terms of the volume of work,
Right.
but I think in terms of the diversification of work, I think I've read from Hindi literature to Urdu literature to English to very modernistic words. So I was The Catcher in the Rye, the core-defining book, um, Freedom at Midnight, to Larry Collins and Dominic Lapierre. That was one of the then the Fountainhead, Ayn Rand series, all those people. And of course, when you are very young and you want to become doctors, you like love stories and doctors by Eric Segal. So these are the books I read. I offhandedly remember reading them. Uh, but after that, when I got into medicine, I could hardly read. That continued till 2015-16, where good for 20 years, 25 years of my life, I didn't read anything.
Mm.
Then somehow, as luck would have it, and your genetic composition of being in Lucknow draws you back to the literature
Right.
and music and culture. So I started appreciating uh, Hindi literature and Urdu literature, from Faiz Ahmad Faiz to Ahmad Faraz to John Elias to you name it, from everybody from Firaq Gorakhpuri to those Pakistani writers. This entire northern belt of shires and poets. I grew very intensely to both Urdu literature in terms of Faiz Ahmad Faiz, Faraz, and things, likes of them, and then also the Hindi literature in terms of Ramdhari Singh Dinkar and Rashmi Rathi and Urvashi and things like that. So coming back to the book, it never intended to happen. I realized, like, somewhere in 2016 and 17, there was a very deep sense of disquiet, if that's the right term to use here, in my mind, that for the same thing, for the same issue, you have different perceptions in different people's mind, and the perceptions change according to what gender you are, what age group you are, what phase of life you are in. For the same thing for a same person. Uh, so the same thing for two different people can have absolutely different meaning at one single
Absolutely.
point of time. And I'm quoting this line from Sage. It says that same thing for the same at the same point of time can have different meaning for two different people.
Yes.
And it's also true that the same thing for the same person can have a two different meaning at two different points of time.
True.
So when you change the time horizon or you change the person horizon, the perception about the same concept changes. You
Mm.
know, so I was kind of disquiet. Me and my daughters used to have arguments about the same thing, which I think that I am right and they think that they are right. this whole conflict of human mind about, and the human minds have common conflicts. You see,
Right.
if you boil down the conflicts, you can make a list of 20, 25 conflicts. What's money? What's power? What's faith?
True.
What's love? So the common conflicts of human mind are limited. But
Mm.
so I started writing essays around those things. So the first essay was touch. The
Mm.
human touch can have a different meaning, and it's kind of a very complex phenomenon.
Right.
The second was faith. The third was, but I realized that when I was writing essays, it was kind of very dogmatic, one person's point of view.
Mm.
So slowly and slowly, the essays converted into a book, and this book is a very fast-moving, fictional story that goes to three different cities, two continents, and it's not a collection of essays kind. This is a very fast-moving story. You can read it like a story.
Mhm.
But if you want to take the detours after every para or after every page or after every chapter, you have to take a pause and delve on deeper concepts of human psychology, philosophy, and towards the end, spirituality. So that's what Sage is. It's a sort of a catharsis journey into your own psyche, and everybody who has read it kinds of have different interpretations of what they feel about Sage. It kind of brings out different emotions in different people. But all I can say, it's a fast moving story, but it's layered psychologically, it's layered philosophically, and it's layered spiritually. That's it.
Beautiful, beautiful. So let me ask you this, sir. What I've noticed over the years, the people, the doctors who are considered, the best or sort of remarkable, uh, they have some. There's one extra element to their life beyond. There was some extra interest beyond the medical thing, right? They're not dogmatic. They're not army generals of medicine. They're medicine plus, right? So do you feel that's true? Because I can clearly see that extra interest. And does that make you a better doctor? The fact that you love literature, the fact that you have interest beyond medicine, does that make you a better doctor? Because medicine is the same, right? End of the day, a lot of the things that we talk about, the common questions which humans ask, one of the question is that what, as doctors, what can you really do, right? A lot of things are, the fate is often sealed, right? So we try our best to kind of land there. But in that journey, if you have additional interest, right, or if you have a sort of a metacognition aspect of it, where you see beyond your medicine, does that make you a better physician?
Uh, that's a very there's a big dichotomy there. So if I tell you what I feel, that when I'm into my department, or when I'm into symbolically wearing that apron when I'm in the doctor's mode, I don't want people and society to think that I'm also an author. I also have an interest in music.
Mhm.
What it does is that it's unfortunate. It's really unfortunate that um, kind of uh, the society really wants us to be very serious, you
Right.
know. And whenever there is a diversion, they kind of they kind of
Takes the
have
edge
this
off.
question mark
Yeah.
in their mind that is it not trivializing their profession? So that's
Right.
a very it's very unique to I don't know, it's very unique to our country probably, because we like to see like
Yeah.
uh, so I don't want to. So if you realize, if you see that when the publisher was publishing the book, I never wanted to write Dr. Rishi Sethi. I said
Right.
Rishi. And I just told the publisher, don't even say Sethi, say Rishi. I don't want
Mm.
let it be a partially anonymous kind
Right.
of.
Right.
I want to mix my medical persona of the administrator, head of the department, managing a large institution versus, a writer. I don't want to confuse my
Right.
my personal self with my professional self. Having said that, the question that you asked is that, does it make you a better doctor? I think definitely yes,
Mhm.
because science and clearing examinations and getting degrees is one part of it.
Right.
And we know that those people who were topping every examination, and this probably after 10 years or 15 years, you hardly see any one of them as leaders of medicine. When I say, I tell my residents that when they are doing DM cardiology, DM cardiology is a farce degree. You're not doing DM cardiology. You are doing a dual degree. You are getting an M Tech in cardiology,
Right.
and you are getting an M Phil in cardiology.
Mm.
So you must know how to do the angioplasties, the echoes, the
Mm.
pacemakers, and all the advanced procedures. That's the M Tech part of
Very
it.
interesting. Mm.
But until and unless you bring the M Phil part of it, what's
Mm.
the philosophy?
Right.
Why should you prescribe aspirin in a stable angina?
Mm.
How long should you give beta blockers post MI?
Mm.
What is the rationale of dual antiplatelet therapy post PCI in stable angina versus acute coronary syndrome?
Mm.
When should you treat stable angina? Until and unless you ask these philosophical questions, take help from data, literature, trials, guidelines, and then form your own philosophy that this is what is going to be, you know, I think until and unless that comes, you don't really become, uh, you don't really reach the top of the pyramid in the field of medicine. To reach the top of the pyramid, you need to be a philosopher in medicine. That's what I feel.
Very interesting. So MPhil and MTech. So in endocrine, we are all MPhil only, no
Yeah,
MTech.
yeah, yeah.
So,
That's why I brought
so
it
all
up.
philosophy. So
Yeah.
yeah, very interesting. Very interesting takes. I think that's great. So talking about literature and with this little sonnet, and which kind of ties in with what we're going to discuss today. So what we understand is nature is cruel. Okay, one of the things, like I said, humans grappling with reality. But I mean, animals, living beings grappling with reality. We often kind of put that little bit of a blinker, saying that we often kind of turn a blind eye to the fact. But the fact is, reality is that nature is cruel, right? It's supposed to be. It's not Mother Nature, right? You know it's a cruel nature. It's a stepmother nature, right? So there's a little couplet, once in the womb, so this is nature, she draws a flawless plan, straight pipes, clear walls, a heart that beats on time. And then with a twitch, she wraps the carefully spent, hides knots of muscles, kinks, and arch in rhyme. We name it a variant, right? An aberration, a Lucius naturae, that is cruel nature, a harmless quirk or probably a loaded gun concealed. But she just shrugs. She just says, I drew the map and leaves us hunting where the falls reveal, right? So nature just draws a map, right? Now that a little bit of a point here and there means nothing for the nature as a whole, but for that person, it's the whole world, right? It completely changes, right? So talking about maps of blood vessels, let's go to your story, and that's chapter one. That's your story, the anomalous coronary artery, right? Lessons from the long watch. We want to listen to your story, the interesting one, which you told us. So please go ahead. The stage is all yours.
Yeah. When we had a conversation in preparation for this podcast, and you said the story, no real story actually was coming to my mind, because uh, you want to talk about the scientific aspect of it. You want to talk about the what you did so great, or what you lost some case, or it gave you a pain and memory for life. But somehow, as we were talking, this only one name cropped up in my mind, and for the sake of maintaining ethics and anonymity, I will not take the name. But let's name it. Let's the patient name Atul. Let's
Right.
let's just give him a name.
Sure.
It's not the real name. And we had the resident by the same name, first name, and the same surname.
Okay.
And right now, when I travel the world and give lectures, and many of my lectures are watched by students and appreciated, one of the core lectures that people really like is how do you approach angioplasties and anomalous coronary arteries.
Right.
That's really kind of when you are doing procedures, anomalous coronary arteries um, can give trouble to both the young generation as well as a seasoned interventional cardiologist,
Right.
because whatever you have been trained, it completely flips over and you have to do things differently. At the same point of time, very, very few, I would say, cardiologists or philosophers and cardiologists have a clear understanding that even the anomalous coronary arteries do follow certain patterns. And but every time we get a procedure, we just hit and try. Let's try to hook them. Let's try to hook them. But it's not so much of a so much not so much of a hit and try. But there is some science going there also.
Mm.
And I was also like most of the other people. I had no idea. And this gentleman, let's name him Atul, walks inside one day into emergency. And this takes me back 17 years. This is 2009. I was early into my assistant professorship at George's Medical University, and this patient had, a non-ST-MI. He was admitted to a different hospital. Gross ECG changes, troponins were elevated, and he came to us with emergency in the emergency department. We did an angiogram. The angiogram anatomically, there was no lesion in the coronary arteries, but his right coronary artery was coming out, originating from the left sinus, and it was crossing over and going to the right side. At that point of time, I had no idea what is the path the right coronary artery adopts, things like that. And we always used to think that whenever the artery crosses over from one side to another, uh, it can follow many paths. It can go from behind, it can go from anterior to the pulmonary artery. But if it goes between aorta and pulmonary artery, two great arteries, then there is a likelihood that it can get compressed.
Mm.
That is the dangerous scenario, and that is a difficult thing to do. And that this is the point, and we could find that this right coronary artery was actually going between aorta and pulmonary artery, and we thought that this was the culprit. Although there was no lesion inside the coronary arteries, but a compression might be happening. That was the thing that maximum we could think. But gradually and only, let's say that patient named Atul and my resident named Atul. My resident, of course, is not named Atul, and I could name him, but then I would risk exposing the patient's name also.
Right.
One of the leading cardiologists in Varanasi these days.
Okay.
And he kind of went deep into that patient, and we together could understand. And that was the first time I understood the concepts of anomalous coronary arteries, where we realized that right coronary artery originating from left side almost always 100% goes interarterial, that is between pulmonary artery and aorta, and mostly it is benign, nothing needs to be done. When
Mm.
it's left coronary artery that follows that path, then it's a dangerous one.
Right.
All these learnings we grew up, and then we did an angiogram. At that point of time, we thought that that is causing ischemia. We sent the patients to top surgeons of the country. They refused to operate. And then this patient got followed up with us for almost 7 to 8 years. He developed in between near cardiac arrests. Then we realized that cardiac arrest and things were happening with electrical phenomena and not ischemic phenomena. We had an implantable loop recorder, implanted in him. It picked up in the night time large pauses where there was no electrical activity. Then in 2014, 13 or 14, he got a dual chamber pacemaker, and he just continued to be followed up in between somewhere later down the line because he had this very high inflammatory menu, some sort of autoimmune disease also that I don't offhandedly remember. He had a stroke in 2017-18.
Okay.
The patient continues to do well, continues to be in our follow-up, comes once or twice a year. But probably that patient, the name of the residents, are studying together that patient and trying to learn something new. Even when I was like post DM 3 years, supposedly all degrees were checklist. But when you invest yourself heavily in one patient,
Mm.
which probably you don't know everything about,
Mm.
that patient teaches you so much
True.
that no degree or no kind of exam can teach you. And probably that was an example to me later in my life. That whenever I get a patient circumstance which is confusing to me, which I don't understand, then you invest yourself mentally, psychologically, time wise in that one patient, and that becomes the source knowledge, the key point on which your further medical knowledge kinds of. So when we call it the continuing medical education, it's not
Right.
the seminars and lectures and the evening symposia that we attend.
Mm.
How you invest yourself mentally and time wise in every case that you don't understand, you don't have too much knowledge to. And
Mm.
similarly, many a times when we do angioplasties, you develop an osteal circumflex disease, and it's a very complex phenomenon. And the same knowledge I applied, same principles I applied in osteal circumflex, and probably, understood the philosophical approach to those cases, those phenomena, and probably that makes us, if not better, safer, to see safer doctors, safer interventional cardiologists for our future patients. Even if we learn, something negative from one source patient. So that's why I remember the name of that patient. I remember the doctor, my resident, and who's a leading interventional cardiologist in Varanasi now. And that patient, that resident, and myself, I treat them as all of them. The situation was a teacher, and I learned a lot for them. And now I teach them the same principles, teach others the same principle, and get name, fame, appreciation because of it.
Excellent, sir. Beautiful story. And let me tell you this. I think kind of turning the clock back, uh, when we envisioned this series, and I with some of the ideas which we had very discussion with Netflix and Sun Pharma and other sponsors. One of the things which I had for many years was that we want a show where we really talk about patient stories. Why that is important? Because right now, if you see in terms of the hierarchy of medical literature, case reports and case stories and the other things are actually right at the bottom, right? It's all about evidence-based studies, literature. But like you exactly said, all of us actually learn. We take leaps. So we take the usual drifts of learning from evidence-based medicine, right? So you have a new paper published. That's the point you decide that, okay, maybe I'll not give aspirin for primary prevention. You read a new paper and change a little bit of your practice. But when you see an interesting patient like this, right, you actually, your practice takes leaps, right? Because I mean, the outcome, let's say there's an outcome in a patient which is great, you have the positive spin to it, and plus you have to learn something. But if you have a bad outcome also, that teaches you a very painful lesson, where which no evidence-based medicine can teach you. I think at the end of the day, you take a big leap. And I think in the world of evidence-based medicine, we forget that we actually learn from our patients, right? Everything else is just background noise. It's just random discussions that we have amongst our peers, right? Or when we present papers in the CMEs. The real CME actually happens when you have the patient in front of you, right? That's the learning, real learning which you have. And I think that ties in very well with your story. So let me just take a little bit of a leap from this and tell you one story of mine, which I think where I also learned similarly, and so it kind of ties very well with your story. So we do a lot of thyroid work in terms of we actually done a lot of innovations in that field as well. Now, in terms of thyroid, we get patients with thyroid nodules and goiters and papillary thyroid cancers and so on. And we had this patient, a lot of times, they've come to endocrinologist first, and we work them up, and then we sort of get them operated under our care, and then follow them up post-operatively. So this is a patient of ours who was otherwise a routine, goiter, who had a papillary thyroid cancer, low risk in general, and it shouldn't have been too much of a problem. Most of the time, pre-operatively, the surgeon also wants a pre-operative CT scan, so we send him for a routine pre-operative CT scan. I get a frantic call from a young radiologist who had just joined the hospital. And he says that, can you give me the number of the surgeon? I said, Kya hua? He said, I need to talk to the surgeon. This patient has what is known as an arteria lusoria. I said, what's arterial lusoria? I have absolutely no idea what. Right? So he said, he has arterial lusoria. I said, blank for a moment. I said, what's arterial lusoria? Obviously, I was the senior colleague there, a young radiologist. But for a moment, I waited. I said, I don't know what it is, right? But this is important because he's called me specially for this. He wants the surgeon's number. I said, explain to me what is arterial lusoria. So he said, basically, you have aberrant artery. So I said, उसमें मुझे क्या लेना देना और surgeon को क्या लेना, right? She said, no, you're missing the point. I said, what's the point? So I'll just come to that point in a minute. We'll come back to this story again. So, of course, talked to the surgeon, and I think it was a good call. Uh, the problem was then the radiologist, we later on after a few days met over lunch. He said, I told this to my seniors. They were also, very dismissive about that. But then when I read about this, I think both me and the surgeon had to thank him for something which was, a good, insightful call. So let me tell you this. I started reading about this, right? So when he called me up, and I think, at some point, like I said, we actually give up our MTech degrees when you start endocrinology. You keep that, so it's in endocrinology training, you leave that at the door, that is what we're told, right? So, it's non-interventional first, right? So, read up a little bit on the anatomy and came across this guy called Bayford. Okay. So Bayford, like you said, like you had, was obsessed with one patient, right? Most of his life. There's a lot of publications on this, and ultimately, so you had this one lady who basically had difficulty in swallowing and had dysphagia, and so it was so bad that she had progressive weight loss and ultimately died also of malnutrition. So he kept chasing this this case, uh, did everything, like he was a general surgeon, so he kept kind of following this patient, for years, kept trying to find out what is the cause for the dysphagia. Kept searching for that, right? And couldn't find anything, so obviously the obvious culprits were, I mean, obvious causes could be the GI tract, right? Is she have difficult, some mechanical issues, is there some neurological sense? Just couldn't, from whatever limited technology they had at that time, and from all he couldn't find an answer, right? He couldn't find the answer, and the poor lady died. And a little bit cruel again, but he probably waited for her to die because so that he could actually get the answer to his puzzle, which has been chasing all his life. Immediately did an autopsy, and he found what he called it as dysphagia lusoria, which later on became synonymous with arterial lusoria. So his publication, which he wrote, was what he called it as dysphagia lusoria. Dysphagia, that is cruel dysphagia, right? Which this patient had, right? Cruel trick of nature, which nature played on this lady. So he did the biopsy and the autopsy, and he found this out. The What I read up from this was that you have the the subclavian artery, right? So the origin of the subclavian. The left subclavian, of course, is straightforward. The right subclavian, which is supposed to come from brachiocephalic trunk, it comes distally from the entire arch, right? And then it has to loop around and go back to where it's supposed to go. And because of that, sometimes you could have the esophagus, or even sometimes the trachea, getting looped between the aorta and the blood vessel. And this is what this lady had, and that kind of compressed the esophagus, and she had this difficult dysphagia. So I said, great, right? I read up this, did the cursory reading of this, and I said, fine, looks interesting, but then why would my thyroid surgeon have to really worry about that, right? So then I read up more about this, and then I realized that the recurrent laryngeal nerve, the very name recurrent laryngeal nerve, actually comes from it because it kind of loops around this right subclavian.
Right.
And when the right subclavian itself is not in place, it doesn't loop around. So it's a non-recurrent laryngeal nerve, right? And recurrent laryngeal nerve is the thyroid surgeon's and an endocrinologist's nightmare, because you send a patient for surgery, and there's this positive affirmations which we tell us, patient पूछेगा, कि कुछ problem तो नहीं होगा, मेरा voice तो नहीं चला जाएगा. I heard that, people lose their voice after they undergo thyroid surgery.
Right.
And that's one common thing, right? And that's a common, I had teachers who said that, sir, voice to nahi jayega. मैंने कहा, because my entire life's work depends on my voice, right? I would rather not undergo surgery and preserve my voice than undergo surgery and lose my voice. So, you had this. So the laryngeal nerve is the one, recurrent laryngeal nerve, which is you're most likely to damage in surgery. It's everybody's nightmare. And when you have that recurrent one, right, it's safeguarding the system. But when it's a non-recurrent, go straight, you're more likely to damage it because the surgeon doesn't identify that. And this is a very important read by the radiologist, because then immediately, he called the surgeon. Surgeon was also for a minute perplexed that junior radiologist calling senior surgeon for something which which is arterial. मुझे क्या लेना देना? But then immediately he picked it up. Said this is a good call, right? So of course I need to be more careful during the surgery, right? So that's an interesting story, and I think a lot of aberrant vessels. Any other interesting aberrant? I mean, you of course have now kind of specialized, I would say, in the anomalous blood vessels. So any take on this, sir?
This is also our nightmare because now
Yes.
most of the procedures, almost 95% of the procedures that we do, are right radial artery. And the
Hmm.
right radial artery has to go through the same brachiocephalic to the subclavian and fall. It's pretty straight shot that it goes in the ascending aorta, and then we can engage left to right coronary ostium. But when it's luxurian, it
Hmm.
crosses over to the other side, goes behind the esophagus, then you have to come down. And
Hmm.
sometimes it's nearly impossible to do a right radial procedure when
Right.
it's luxuria. And these luxurias also come in different different types of luxuria. Sometimes you can conquer luxuria and you can do it. Sometimes you can go to the left radial, but more often than not, you'll have to shift to the femoral artery, which is not very comfortable for the patient and it has got a higher complication rate. But as you were speaking, I think this whole concept of having case-based discussion, I
Hmm.
also learned that, in thyroids, I was wondering what's Lusoria got to do with thyroid
Yeah.
surgery again, and you clearly, told us what it was, and similarly the story that I told. But I think most great discoveries in medicine have happened through a single patient
True.
or a single incident.
Absolutely.
Whether Frostman injecting himself with Foley's catheter and trying to cat the heart from his brachiocephalic vein, or and as you were saying, I was remembering it's the 52nd year probably of the discovery of beta blockers.
Hmm.
James Black discovered beta blockers, and why did he went on to? His father died of myocardial infarction,
Right.
and a thought occurred to him that and the only treatment for myocardial infarction at that point of time was rest.
Hmm.
You just relax the heart. So he
Hmm.
thought that if I could have an agent that can slow down the heart rate, that would have a better demand supply mismatch between the work done by the
Hmm.
heart
Hmm.
and the blood supply to the heart. So he discovered beta blockers, and what
Right.
wonders done over the course of years. Similarly, I remember a story of the pacemakers being developed. So I think it was Karolinska's Institute in Sweden, and there was this one patient and his wife who used to bug the surgeons, bug the engineers, that my husband is having syncopes, he's falling because of absence of electrical activity. Built a machine around it, and they discovered, and the engineer and the surgeon at that point of time, now cardiologists implant most of the pacemakers, but then it was surgeons, and they kind of discovered a small electrical circuit which they implanted in the rectus sheath and epicardial, and through the diaphragm they had this lead going and connecting with the muscle of the heart externally, and that was the first pacemaker which lasted few days, and the lead got broken. And then I think I'm forgetting the year. It was 59 probably or 69. But 69 probably is the right answer. I don't remember that. But over the course of time, that patient, whenever he had the complication of that pacemaker,
Hmm.
he went back to the surgeons and the engineers, and he forced them to innovate more and more. And
Right.
he had like multiple replacements of pacemakers.
Wow.
And the funny part of it is that patient outlived both the surgeon as
Wow.
well. Yeah. so,
So,
so
yeah.
and the first pacemaker, the electrical circuit that they built, they did not have a casing. How to
Hmm.
keep how to how to keep that in a case?
Hmm.
You know what was taken as the case to put the circuit? A box of kiwi shoe polish.
Okay.
Polishes.
It's a perfect size for. Yeah.
And
So
that's why sometimes when we still replace the pacemaker,
right.
without knowing the story, almost all this cardiologists say, "Oh, a box replace karte hain." When they're
Right.
talking about the pulse generator replacement, They
Wow.
actually commonly with box replacement hair. So they don't realize that it was actually the kiwi shoe polish box that gave. That's
It's
also a
pretty good.
miracle.
Yeah. No, I think so that's, I think the greatest discoveries happen that way, right? So it's
Yeah,
lot of it, because, I think there's this concept in tech also, which is basically moonshot,
yeah,
right? So you know unless you take crazy ideas forward, science doesn't really move. It just moves, it keeps moving very slowly, right? So your moves keeps moving in an inch until you have somebody who, maybe a crazy billionaire like Elon, who would say, no, let's start shooting rockets to the moon, right? At a private equity level, right? So I think you need that edge. You need somebody who is edgy, who is kind of going to take that leap of faith, and take that, even for SGLT2 inhibitors. And this is what this is what Ralph DiFronzo claims, right? So he is still around. He keeps talking about it. Uh, he Interesting thing is, Ralph DiFronzo, though famous in diabetes and endocrinology, he started his training in nephrology. There's a nephrology. He first, was trained in nephrology, and then he went on. He changed his interest and went on to do endocrinology, because he had that initial training in nephrology. He was still connected to that, and he kept, he was also obsessed with this one patient who basically had familiar glycosuria. He kept reading about it. This patient with familiar glycosuria, kept reading about it. That was when he was doing nephrology. Now we changed to endocrinology. He had this sudden thought that, if this uh, you know glucose keeps going away in the urine, then probably it's not going to stay in the system. If it's not going to stay in the system, the problem of hyperglycemia sort of is solved to an extent, though in a very unnatural way. But maybe, who knows? So then he went, tried to read more about it, and found out that, the apple bark has fluorescein, which is basically has SGLT2 inhibitor properties. He kept pushing and bugging the pharmaceutical industries to build that. Nobody took him seriously. Nobody took him seriously, right? Initially, for many years, even though he had by the time become a big name in his field, nobody thought. I think this is a crazy Italian coming up with a crazy idea, right? That's what everybody kind of dismissed it. So much so that, after some time, their idea started taking traction, with some initial phase one studies showing some promising things. But people were still very skeptical about SGLT2 inhibitors, right? Nobody really thought that iska koi future aega. Uh, there's a series called Billions. I don't know if you've watched that. That went very early season. So there's basically a story between a venture capitalist, a sort of an investment banker, versus, a prosecutor. So this one episode where, hypothetical case, this is at the time where SGLT2, were in the early phases of the trial. So this company, this investment banking firm, puts their entire money in one bet, and that bet is on that pharmaceutical company, which is going to launch the SGLT2 inhibitors. Their phase three trial is just about to be released, right? They put their entire, money behind that, betting that if it kind of works, suddenly it will save their firm. A cruel fate of nature is that it turns sideways, and the trial comes out negative, and the CEO of that pharmaceutical company resigns, and their entire savings, their entire bet which the, investment company had, goes down the drain. The interesting thing is that when that real empiric trial, what was hypothetical, really came out, where they would actually have made billions, right? Because it turned out to be, from the author's perspective, it was a negative trial, but in reality, it turned out to be completely a positive one. And I think the rest is history now. SGLT2 inhibitors are, uh, I think, legend, in its own way, not only in endocrinology and cardiology, but even nephrology and many other fields, right? So I think
yeah.
it's right then. That so I
So,
completely agree with you. I think, uh, yeah, same.
so I deal with a bit of medtech innovation, and there is the thing that an idea that changes everything, the moonshot. It's not a technical. I mean, that's the term we use is that uh, disruptive technology.
Correct.
It disrupts the chain
Right.
of natural thought process. So if
Absolutely.
you have a disruptive idea, many a times you will be seen as a crazy person, but only the disruptive ideas can really, really,
Change.
if
Yeah.
they're successful, change the fate of the society, the world, the global thought process. So disruptive ideas is something that as innovators would really try to look at. And of course, we realize that not all disruptive ideas are
Good.
successful, but
Yes.
there is a method in the madness also. If you
Yes.
follow the method, it's not that I have a disruptive idea, build a ladder to the moon.
Hmm.
So you have to have a couple of. If you are trained in 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 thinking, in innovative thinking, and be it intuitively trained or trained under someone or scientifically trained,
Hmm.
you are more likely to catch the disruptive ideas that may succeed and
Correct.
increase the chances of success of that disruptive idea. Yeah.
Absolutely. So I think great. That was fantastic. I think we had a lovely discussion. So that's the whole point. And I think I'll just uh, end here. And thank you. I think it was wonderful discussion. I think we went we went beyond what we had initially thought, and we're right on time. I just end with this one line again from nature, and then these aberrant arteries. But she just shrugs and we drew the map and leaves us hunting where the faults are revealed. Okay, so nature just drew the map, and then it's for the cardiologist to figure out the route of getting into the coronary. So yeah, so I think
And the
thank you so much.
endocrinologist and the
And
endocrinologist.
the endocrinologist as well, right? So yeah, thank you so much. Thank you for being such a wonderful guest. I think the first season one, episode one was season two, episode one was just fantastic. Thank you so much, and Haley, back to you.
Thank you so much, Dr. Rishi and Dr. Om, for joining us tonight. I think we had life lessons and medicine lessons. So it was a pleasure listening to the two of you. Thank you to all the audience members who joined us for the session. Please keep an eye out for the next episode. We will be coming out with a notification soon. Thank you so much and good night, everyone.
Thank you.
Thank you. It was really a joy to interact with all of you. And to Om, it was fantastic we have not met in person, but I'm sure we should be meeting in person
Absolutely.
soon. But it was a real joy to interact with all of you today evening. And thank you, Mr. Om, for having me on this
Thank you,
podcast.
Dr. Rishi. It was wonderful. I think I told Haley the first time we connected. I think this is going to be superb, right? So I think
Yeah.
so a great beginning of season two, episode one.
Thank
So
you.
thank you.
Thank you. Best wishes. Good night.
Good
Good
Thank
night.
you so much. Good night.
Good night.